I did the use of buprenorphine for opiate dependence in the correctional setting. Opiate dependence is a severe and growing public health problem in the United States. It is estimated that almost 900,000 Americans are currently opiate dependent, with heroin being the most common. Over 146,000 new individuals began using heroin in 2000, a number that continues to increase. Opiate users are more susceptible to infectious diseases such as HIV, hepatitis B and C, and tuberculosis. Mortality rates among heroin injectors are between 6 and 20 times higher than drug-free individuals. Opiate use among state and jail inmates is between 12 and 15%. Due to the high number of opiate-dependent patients that enter and re-enter prisons and jails, the correctional system is one setting where access to necessary opiate treatment can be greatly expanded. Additionally, the structured environment of the correctional setting can be an ideal place to initiate drug treatment. Currently, only 32% of state prisoners and 36% of federal prisoners with substance abuse problems receive any form of treatment while in prison. Data suggests that a large population of inmates want treatment in prison but are unable to access it. On the outside, only 15% of opiate-dependent patients receive pharmacological treatment. This is counterproductive for the criminal justice system because in the absence of prison-based treatment and linkage to community care following release, drug abuse and recidivism rates will remain high. The Federal Drug Abuse Treatment Act of 2000 opened a window for opportunity for individuals who are addicted to drugs and increased access to options for treatment. Previously, only methadone maintenance, which is approved for use only through specially regulated clinics, was available to treat opiate addiction. Now the Act allows any physician who takes a short specialized training course to become certified to prescribe buprenorphine for this purpose. Physicians can prescribe sublingual tablets of buprenorphine and buprenorphine naloxone, which is Suboxone, in a traditional office setting to treat patients with opiate dependence. Buprenorphine is effective for the treatment of opiate addiction, including dependence to heroin, oxycodone, morphine, hydrocodone, methadone, and other opiates. Prior to beginning buprenorphine treatment, the patient must be abstinent from heroin and other abused opiates long enough to manifest some withdrawal symptoms or be tapered to a low dose of methadone before switching to buprenorphine. Buprenorphine is preferred over methadone because it is available in a sublingual dosage form when combined with naloxone to prevent abuse. The study by Magora et al. Said that methadone maintenance has been the primary treatment for chronic opioid dependence since the 1970s. At least 20 countries provide methadone maintenance in prisons or jails. A major obstacle to expand access to methadone maintenance for inmates in the U.S. is the unfortunate stigma that has become to be associated that methadone substitutes one addiction for another. Buprenorphine has certain potential advantages over methadone as a treatment for opiate-addicted jail inmates and other criminal justice populations. Buprenorphine has lesser subjective agonistic effects and milder medication withdrawal as compared with methadone. The setting of the study conducted by Magora et al. Was the key extended entry program. The sample was Rikers Island Jail, which is in New York City. During 2007, 109,000 offenders were admitted to Rikers and 15,838 received opiate withdrawal service using methadone and 4,836 received methadone maintenance through KEEP. Within the jail, KEEP participants received referrals to participating community methadone programs at the time of their release. Inmates provided informed consent were assigned either to buprenorphine or methadone maintenance conditions. Methadone was treatment as usual. The results showed that 82% of buprenorphine and 75% of methadone patients completed their assigned treatment while in jail. Methadone patients were in treatment at Rikers significantly longer than buprenorphine patients. At entry to treatment at Rikers, buprenorphine patients stated an intention to continue treatment after release more often than did methadone patients. buprenorphine patients showed more often a medication-assisted treatment provider than did methadone patients. 5 out of the 56 methadone-assigned patients went to buprenorphine provider rather than a methadone clinic after release, but no buprenorphine-assigned patients went to a methadone clinic. The study by Nunn et al. Emailed or faxed a 17-question survey to 50 state Department of Corrections facilities. They also surveyed the Federal Bureau of Prisons and the District of Columbia Prison. Survey questions address opiate screening practices, including methadone and buprenorphine provision within the prison setting, attitudes about the usefulness of buprenorphine and methadone, and prison opiate replacement therapy, referring practice of the inmates leaving prison. They received a total of 51 of 52 responses. Although methadone is offered more frequently than buprenorphine, only 55% prison systems offered methadone under any circumstances. Methadone use varies widely across states. Some states report treating more than 500 patients with methadone, but over 50% who offer methadone do so exclusively for pregnant women with acute opiate withdrawal or for chronic pain management. Is estimated that between 1,614 and 1,817 prisoners receive methadone in state and federal correction systems nationwide. 7 prison systems offer buprenorphine in some circumstances, and 15 offer referrals for some inmates to community buprenorphine providers upon release. Is estimated that between 57 and 150 prisoners receive buprenorphine in state and federal corrections systems nationwide. The recent expansion of buprenorphine to the primary care setting provides potentially exciting opportunity to revisit the use of opiate substitution therapy within the correctional and corrections community setting. The relative lack of high costs of methadone maintenance in most communities, the unique pharmacological properties of buprenorphine as a partial opiate agonist, and less stringent regulations of buprenorphine compared to methadone are compelling reasons to consider buprenorphine substitution therapy for the correctional and transitional settings. However, structural obstacles exist with implementing buprenorphine in the correctional setting.